Hi, this is QD Clinic. I'm Jack Cush with RheumNow. QD Clinic's more than the data, more than the trials. It's about connecting the dots between clinical practice and that which you are taught by the experts, and really connecting the dots so it makes sense to you. We hope to see you at RheumNow.Live. Today's case is recurrent fevers to 103. 43-year-old white male has a history of hypertension, diabetes. He's been in the hospital a few times for these fevers. He was hospitalized last month with a fever of 39 degrees centigrade, lasting 3 days, and said it went away when he was given steroids. All of his prior episodes are fevers that last for 3 days, and they usually resolve either with antipyretics or with a course of steroids. When he comes to see you, he just got out of the hospital. He's on prednisone 40 milligrams a day. His past history is notable for a chronic sore throat, but he has no weight loss, no myalgias, no rash, no hair loss. When you examine him, he has impressive synovitis of multiple joints, wrists, MCPs, knees, and ankles. He has a few cervical lymph nodes that are non-tender, mobile, bilateral, and on chest X-ray, he has hyaluradenopathy. His white count is really elevated, as are many of his labs. His white count's 42,000 with a left shift. He has a mild anemia, albumin of less than 3. His SED rate's 85. His CRP is 11 milligrams per deciliter. That's 110 milligrams per liter. His ferritin is over 40,000. His other tests, ANA, rheumatoid factor, CPK, aldolase, CCP, LFTs, SPEP, really are not diagnostic or negative. He has a bone marrow biopsy showing increased cellularity of all lineages, and the bone marrow, blood, urine are negative for bacterial infection, fungal infection, and TB. Question is, what's your diagnosis? Well, I'm sorry if you've been thinking that this is Still's disease, because it's not. The gentleman has 3 days of fever and it goes away. If you didn't give him steroids, it would still go away. It may go a little bit less, and then how many times you have a fever, it's unpredictable. In a month, he might have 2 or 3 episodes. In 6 months, he might have 2 or 3 episodes. It has no periodicity or reproducibility. Still's disease in kids and adults is a daily fever at the same time, usually late at night or late in the evening. It goes up and it comes down. By morning time, when you have your endogenous cortisol, they usually are afebrile. So this patient, if you look at the Yamaguchi criteria, would meet Yamaguchi criteria, but you'd have to count the fever. And if you don't count the fever as being typical, then he wouldn't meet Yamaguchi criteria. He doesn't meet the Cush criteria. If you're not sure what the criteria are, you can go to stillsnow.com, and there is a criteria calculator that you can figure out whether the patient has Still's disease or not. The question is, what could this person have? This is an adult onset disease. Let's go right to the rare one, Schnitzler syndrome. An adult onset autoinflammatory condition looks just like this, although they tend to have daily fevers with Schnitzler syndrome. The diagnostic test there would be the presence of an M spike or monoclonal or polyclonal gammopathy, which goes along with Schnitzler syndrome. But the 2 to 3 day history is very reminiscent of familial Mediterranean fever. There are not too many conditions that will give you 2 to 3 days of fever. TRAPS will give you 10 days, 14 days, 20 days of fever and then go away. FMF, 2 to 3 days makes a lot of sense. But you need to diagnose that with genetic testing. This person was seen at the county hospital. The county hospital wouldn't order the $100 autoinflammatory panel from Invitae.com, so he doesn't get the diagnosis confirmed by genetic testing. Instead, he gets treated with anakinra. And you know what? He did well. Fevers went away. Sore throat improved. Polyarthritis got better, but did not get totally better. And he needed to go on methotrexate and still be on steroids. You can see the problem of not having a firm diagnosis here. does translate to some uncertainty with regard to his therapy. Now, maybe he could do better if he was on methotrexate in high doses at a regular every day or every week, I should say. Or maybe instead of methotrexate, he could be on azathioprine or leflunomide or some combination thereof, along with a cytokine inhibitor. And IL-1 is the only one that's approved, and that's canakinumab. So maybe we do better by switching to long-acting canakinumab if we could get it paid for. These are difficult cases. The only other thing that was on my differential was because the man is from Brucella, not Brucella, the land of Brucella called Mexico. People from Mexico will often go back and eat unpasteurized dairy products. So brucellosis is not uncommon and could present like this. So that's an easy antigen-based assay that you could test for to rule out that particular diagnosis, along with other infections that should be done in cases like that. That's it for this episode of QD Clinic. Tune in for more.